Hello, Dr. Elliott and classmates. It's Stacy Starnes here. I'm excited today to share with you some information about the assessment that I've researched, which is the Patient Health Questionnaire. It's also known as the PHQ-9. This is a screening test for depression. The reason that I decided to look more into this particular assessment is because I was talking with my supervisor about some of the go-to assessments that he utilizes in his practice. He sees a lot of clients who deal with depression and anxiety, and especially those who are dealing with PTSD and the effects of coming home from war. So I was excited to learn more about it and to see if this was something that I would like to implement in my future practice as a clinician. The history of the PHQ-9. The PHQ-9 is the 9-question depression scale of PHQ. The PHQ is a self-administered version of the PRIME-MD, a screening tool that assesses 12 mental and emotional health disorders. The PRIME-MD was developed by Pfizer in 1993 to help primary care physicians diagnose psychiatric disorders. Pfizer's goal was to broaden or expand prescribing Zoloft, which Pfizer started selling in 1991, outside of psychiatry. Dr. Robert Spitzer, Dr. Janet Williams, and Dr. Kurt Kroenke and colleagues from Columbia University developed the PHQ in the mid-1990s and the PHQ-9 in 1999 with a grant from Pfizer. It was developed in order to help identify mental health issues such as depression and anxiety that may be causing or increasing some physical health concerns. Here is an example of the PHQ-9. You can see it is very simple. It's one page. On the left, there are 9 problems that everyone is supposed to look at. And then there is a scale from 1 to 3. And at the very bottom, there is one other question that is not ranked according to number. And it says, if you've checked off any problem, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people? The PHQ-9 evaluates the following areas: loss of interest and pleasure in doing things, feeling depressed or hopeless, difficulty sleeping, either sleeping too much, falling asleep, or having problems staying asleep, feeling fatigue or lacking energy, overeating or a loss of appetite completely, feeling like a failure or that you have disappointed your family or yourself, difficulty concentrating, such as when you're watching television or reading the news, moving or speaking so slowly, or the opposite, speaking so quickly and being fidgety, or thinking you're better off dead or wishing you could hurt yourself somehow. Basic implementation of the PHQ-9. Like I said before, it's an instrument for making criteria-based diagnosis of depressive and other mental health disorders commonly encountered in primary care. It's a 9-question depression scale from the Patient Health Questionnaire, the original PHQ. The results of the PHQ-9 may be used to make a depression diagnosis according to the DSM-5 criteria, and it takes less than 3 minutes to complete. I might add that other methods of evaluation are encouraged to make a more holistic type of diagnosis. The total of all 9 responses from the PHQ-9 aims to predict the presence and severity of depression. Primary care providers frequently use the PHQ-9 to screen for depression in their patients. So this is how we interpret the results of the PHQ-9. The total sum of the responses suggest varying levels of depression. Scores range from 0 to 27. In general, a total of 10 or above suggests the presence of depression. Listed below are PHQ-9 totals, the levels of depression that they relate to, and the suggested treatment for each level of depression. Those things you'll be able to see on the next slide. But you can see that it's broken down into the 4 areas, 0 being none at all, 1 being several days, 2 being more than half of the days, and 3 nearly every day. So here's the interpretation of the results. A 0 to 4 is a depression severity that is minimal or none. And here they should just be monitored and they may not require any treatment at this time. A 5 to 9 is mild. And this is where they should repeat the PHQ at a follow-up appointment. 10 to 14 is moderate. It's important to use clinical judgment here to determine the necessary treatment moving forward and to follow up with the client. 15 to 19 is moderately severe. This warrants active treatment with psychotherapy, medications, or a combination. If there's a poor response to treatment, a specialist should be considered. And that is the same path that should be taken if the depression severity is severe. Moving on to validity and reliability. Multiple research studies have evaluated the reliability or consistency and validity or accuracy of the PHQ-9. The results have repeatedly demonstrated that the PHQ-9 is an effective way to measure depression. Studies have verified that the PHQ-9 accurately identifies the presence of depression as well as measures the severity of depression. Populations that were studied to evaluate the PHQ-9's effectiveness include women at a general internal medicine clinic, patients at a family practice, and women at an obstetrics clinic, as well as in individuals with epilepsy, migraines, diabetes, coronary heart disease, spinal cord injuries, multiple sclerosis, cancer, cognitive impairment, HIV, and glaucoma. That's just to name a few. There were many studies done on the validity and reliability of the PHQ-9. The PHQ-9 has also been studied across the ages of adolescents, middle-aged adults, and older adults. Some studies have also looked at how well the PHQ-9 detects and measures depression in other languages, countries, and cultures, including Spanish and British Sign Language, as well as rural China, Nepal, Japan, Germany, and Uganda. Research results have demonstrated that the PHQ-9 is an accurate measure of depression across several languages, countries, and cultures. Additionally, one study found that the PHQ-9 can be administered over the phone and will provide fairly accurate results. This may be beneficial in following up with people who are unable or unwilling to come in to an on-site appointment. I'm going to go ahead and skip this slide, but this is a scenario or one of the studies that was done on neurologic populations, and I will include that so you can go back and look at that if you'd like to. The theory of personality that I feel correlates mostly with the PHQ-9 is the trait approach to personality. The approach assumes behaviors determined by relatively stable traits, which are fundamental units of one's personality. Traits predispose one to act in a certain way regardless of the situation. This means that traits should remain consistent across situations and time, but may vary between individuals. There's an emphasis on measuring personality by using psychometric tests, and these scores are quantitative. A person's given a numeric score to indicate how much of the trait or depression in this situation is that they are dealing with. There are many appropriate populations for this assessment. It's appropriate for individuals who are 12 years old and older. It's used in the general population and used in primary care settings. It can be used without adjustment in different racial and ethnic groups and be a useful tool to help meet the mental health care needs of diverse populations. The advantages of the PHQ-9 are that it is shorter than other depression rating scales. It can be administered in person by a clinician, by telephone, or self-administered. It's available in at least 13 languages. It provides assessment of symptom severity. It's well validated and documented in a variety of populations. It can be used in adolescents as young as 12, and there's no cost associated with this assessment. So it's very cost effective. The disadvantages are it's not a diagnostic tool alone typically, and thus if patient's score is greater than or equal to 10, they're going to need further evaluation for the diagnosis of depression. And it has not really been examined for administration to psychiatric patients. So to wrap up, what was confusing or hard to understand? For me, there were so many pages and pages of statistical results with the PHQ-9. So many populations, it became a little daunting to try to sort through and figure out what I was reading and what was important. I would say overall, what I learned from this experience is that I definitely want to implement the PHQ-9 in my future practice. I can see it as a very effective screening tool. I think it's really beneficial for tracking symptom improvements. It's because it's so short and easy to add. It's something that can be done at the beginning of sessions to see where the client is at. It's also very common, so it helps in communicating information with other colleagues or doctors. And it can be motivating to patients who are filling it out and looking at where they're at. I do like the simplicity, and I hope to implement this in the future. So overall, the PHQ-9 is a test that can be self-administered. It's short, taking just a couple of minutes to complete. It's free, and it's been shown to be effective in multiple settings and situations. It also does not require significant training to administer or to score, making it a simple and effective way to evaluate depression. And identifying depression is an important step in effectively treating the whole person. The PHQ-9 is an accurate measure of depression, accomplishing this task both quickly and easily. I thank you for your time listening to my presentation, and I hope you enjoyed learning more about the PHQ-9. Thank you very much.